Hi everyone, my name is Priyesh and I'm currently QUESMED's Digital Teaching Fellow. Today I'm going to give you a quick tour on how to get the most out of our platform. So once you've bought a subscription and you've entered the QBank platform, the easiest way to start doing a set of unseen questions is hitting our Quick Start button. Then you'll see that for each question we have detailed explanations on why each answer is correct or incorrect, and we also have a page associated with each question. This goes into depth on everything that you need to know for that condition. Next, I'd like to show you our flashcards, and these are based on an AI algorithm which takes into account the questions that you've got wrong and need to learn further to produce a daily set of flashcards which you can then rate to then further help determine what you need to see on the next day. And as I mentioned, these refresh every single day. We have mock tests on our platform as well, including prescribing assessments. And as mentioned, we have a detailed knowledge library, which is a textbook covering exactly what you need to know for your exam for each condition. For example, acute coronary syndrome, where we have a summary followed by all the important aspects of the condition, including references at the end. We also have videos which cover tutorials as well as lectures. And just to quickly show you, we also have an OSCE which will cover the practical elements of your exams, including A to E assessments, communication skills, examination stations, and history taking stations. So for example, with each and every station, we can take them under timed conditions, and this is something that you can do with your friends where you can each take up a role and you can practice and go through them together. And for each OSCE station, we also have a walkthrough on how to approach that station as well. So that's everything that I wanted to cover today. That was a whistle-stop tour. If you have any other questions, please email us at info@quesmed.com, and I hope you found that useful. Thank you for watching.
Hi everyone, welcome to another PSP. So this session will be focused around gynecology, specifically disorders of the ovaries and pelvis. Myself, Izzy, and Ash will be presenting this PSP. So here's a list of topics covered. We do have quite a big range of topics. We've tried to keep this presentation succinct. So each topic will be covered with key points based around a case-based discussion. So just a disclaimer, these are student-created resources made for students, and we acknowledge there may be inaccuracies or errors. We do strive to be accurate, and a lot of work has been put into this presentation, but we acknowledge there are mistakes. If you identify any errors, just please let us know and we can make corrections. Right, so we're going to start with a heavy menstrual bleeding case, which builds on quite nicely from our first PSP. So we've got Megan, a 27-year-old female who has heavy, painful periods. Ash is going to help us go through the case. So Ash, what differentials jump to mind?
Well, based on common differentials from the abnormal uterine bleeding and palm coin, which was explored in our first PSP, the first things that pop up in my mind are things such as endometrial polyps, adenomyosis, lyoma, malignancy, and hyperplasia, coagulopathies, ovulatory dysfunction, endometrial causes such as endometriosis, and also iatrogenic causes.
Yeah, so great. So now that we're looking at Megan's age and just what we know from previous PSPs, things such as fibroids, malignancy, adenomyosis are less likely. They're not impossible, but these conditions often occur in older women or perimenopausal women. And in ONG, this is an important thing to consider with your gynae heavy menstrual bleeding differentials, and will help you figure out what's going on in an OSCE or an exam question.
Yeah, that makes sense.
Alrighty, so we've just got some more info here on Megan. So she's had painful periods for the last few years, and she gets quite severe lower abdominal pain during her period. They last for full 5 to 7 days, and she gets some back pain as well. The periods are very regular, but they are heavy, and at its heaviest, she must change her pad every 1 to 2 hours. She experiences some deep pelvic pain during sexual intercourse as well, and vaginal examination just reveals some minor tenderness. There's no masses, and she's otherwise quite well, and she's got no other medical conditions or regular medications. She's never had any STIs or pregnancies, and in terms of her family history, nothing too significant, except her mother did also suffer from quite painful, heavy periods. Move on to some investigations that are common in heavy menstrual bleeding. So looking at Megan's investigations, so has hemoglobin of 98, which is low. She's got ferritin of 11, which is low. FBE is fine otherwise. Her PCOS screen is negative. Thyroid function tests and colleagues are normal, and beta-HCG is negative. So what else, Ash, would you like to know in terms of investigations?
I'd also like to look at an ultrasound to rule out any structural causes for abnormal uterine bleeding and dysmenorrhea.
Yeah, great. So this follows abnormal uterine bleeding workup. So transvaginal ultrasound findings, we've got hypoechoic thickening on the uterosacral ligaments and endometrial lesions on the parametrial region and urosacral ligament. So kind of with everything that's going on, what is your most likely differential diagnosis?
I'm thinking that this sounds like endometriosis.
Great. So correct. This is endometriosis. Now you see I've got these little bumblebees here. This is just to key some phrases which are buzzwords for your exam, so some good things to remember. So let's look at endometriosis and R1. So in this case, we've got a very typical history of Megan for endometriosis. We've got menorrhagia, dyspareunia, dysmenorrhea, and secondary iron deficiency anemia. Pain can radiate to the back, as it does in Megan's case. And in some women, it's also important to think about that endometriosis can also present with infertility, and sometimes this is the only symptom. They come in being unable to conceive, and then endometriosis is picked up. So on examination, there are hallmark signs of endometriosis, and these are quite buzzwordy for your exams, such as adnexal mass, tenderness in the pouch of Douglas, the fixed retroverted uterus with limited mobility. But keep in mind that a lot of women will have quite normal examination findings on vaginal examination, and these findings can often only present in severe disease. Now, ultrasound will not always show endometrial lesions. It's very specific, a transvaginal ultrasound for endometriosis. It's got around 97 to 98% specificity, but sensitivity is quite broad, from 40 to 70%, and really depends on the kind of endometriosis and where it's located. So the gold standard for definitive diagnosis is a laparoscopic exploration with histology.
So that makes sense. How would we explain this to Megan? She wants to know why she's getting these painful periods.
Yeah, so I'd really start by just kind of explaining what the diagnosis is and what's going on. So if I was explaining it to her, I'd say endometriosis is a condition that can affect the ovaries, pelvis, and the bowel, and it involves something called endometrial tissue, which normally lines the uterus and is shed during a period. But in endometriosis, this is found outside of the uterus rather than inside. This is something we call ectopic tissue that can affect many structures in the pelvis, such as the urosacral ligament, pouch of Douglas, which are ligaments and anatomical structures around the uterus. And the bowel can affect the sides of the pelvis and also the ovaries. And it can even grow into the bladder or the bowel. It occurs over many years, and the tissues actually undergo hormonal changes throughout the menstrual cycle, which then you get bleeding, inflammation, and the uterus and the pelvis gets very inflamed and angry. And then it tries to heal, and you get basically fibrosis and scar tissue forming. And this is when you can get adhesions, which can lead to severe disease and pain. Now, in terms of how endometriosis is different from adenomyosis, you can think of them as like sisters, and adenomyosis is like the big scary sister of endometriosis. I mean, they're both pretty bad, but anyway, for the purpose of this analogy, adenomyosis is very similar. However, one affects women of an older age demographic and often multi-parity women. And the endometrial tissue is located in the myometrium, the muscle of the uterus. And it can actually enlarge the uterus and becomes quite boggy. While in endometriosis, the endometrial tissue is always outside the uterus in endometriosis.
And are there any risk factors and causes for endometriosis?
Yeah, so the mechanism isn't really well understood, but some risk factors are family history, early menarche, and nulliparity. And we talked about infertility and how this can sometimes be a presenting complaint in asymptomatic women.
So what are our management options for Megan? Can she only get surgery?
Yeah, so surgery isn't the only option. It has the best effectiveness in terms of treatment, and we can use it to diagnose. However, we have lots of medical therapies we can use. And given Megan is in pain and she's anemic, we just want to manage her as soon as possible. Patients can wait quite a while in the public system before they can get surgery, so don't delay management. So endometriosis management, it has an MDT approach as it's quite complex, so it needs to be individualized with lots of different specialists. We can manage her pain with NSAIDs. We have tranexamic acid, which is taken on the heaviest days of bleeding to reduce bleeding. And a reduction in bleeding will help treat the iron deficiency anemia, but we can also treat this with tablets in Megan's case, or if she had a very low ferritin, you can consider a transfusion. Now, hormonal therapies are very important in endometriosis as a medical therapy. So they suppress menstruation, they shut down all the endogenous hormones, which then prevents the glands from developing and endometriosis from developing and growing. So this can be the combined oral contraceptive pill. You've got progesterones such as like the IUD, which the levonorgestrel IUD or the Mirena IUD, which has shown great efficacy, and also progestin mini pills. And in very severe cases, you can use GnRH agonists as they shut down the HPG axis. You get a hypoestrogenic state, and they can be administered up to 6 months. And then, of course, we have surgical management. So we explain these options to Megan, and she's very happy to go with the simple pain relief and hormonal therapy at this stage. But she also mentions to you she would like to start some contraception. So Ash, what kind of things would you like to ask?
Yeah, before prescribing her any contraception, I'd want to ask her for a brief sexual history, how long she'd like contraception for, and if she's had any previous contraceptive use, if she has any preference for oral versus intrauteral, and if she has any history of any arterial diseases such as AMI, hypertension, or venous disease such as DVT or PE. Also, whether she has migraines with auras or any history of cervical or breast cancer. It's also important to ask about her smoking status and her general long-term contraceptive plans.
Great. So these are some things we want to ask when we're assessing someone's long-term or assessing someone's suitability for contraception. So when we look at Megan, so she's been sexually active since she was 18. She's been with a long-term male partner for 5 years. She previously took the oral contraceptive pill, but she didn't really like it. She didn't like having to remember to take it every day. And she's been using condoms since. The last STI check was normal, and she's got no history of STIs. She's got no other significant history of arterial venous disease. She doesn't get migraine. She's a non-smoker. And she's actually looking for contraception that she can just forget about and something that will last 5 to 10 years. So what do you think is suitable for Megan?
I would say, given her preferences and also her endometriosis history, I think Amenorrhea, the levonorgestrel IUD, would be most suitable. This would not only help control her heavy bleeding and endometriosis, but it would also provide her with the effective and long-term contraception she's looking for.
Yeah, so it sounds like a great idea. So now we're just going to touch on contraception, which again is another R1. We're not going to go through every option in detail, but I have a lot of slides and tables up with some key information. It's important just to know when you would use certain contraceptions and how to cancel on contraception. This could very likely be an OSCE station. It was for us in 2023. Alrighty, so just talking about short-term contraception. So we've got barrier options such as male condoms, diaphragm, and the vaginal ring. All of these offer STI protection in the vaginal ring, except for the vaginal ring. But the vaginal ring is the only one that contains hormones. So these are great non-hormonal options. They're quite accessible as well. However, effectiveness can vary and can drop below to 90% depending on user use. Then other short-term options include the combined oral contraceptive pill. We've talked about how this can be helpful for endometriosis. Basically, suppresses ovulation and needs to be taken every day. They make periods lighter. You can skip menstruation. You can suppress heavy menstrual bleeding. And we also have progesterone-only pills, which do a similar thing, suppressing ovulation. And these are safe in breastfeeding immediately from birth. So we can recommend them to women postpartumly. So common side effects of any hormonal contraception are going to include mood swings, bloating, headaches, and just be mindful that the combined oral contraceptive pill is contraindicated in migraine with aura. There's just a very small increase in thrombotic risk and also cervical and breast cancer risk. Now we're going to move on to our LARCs, or long-acting reversible contraception. So very common, very popular one. We have hormonal IUDs, which Megan would be suited to. So these are very effective and can last up to 5 years. The copper ID is also another long-term option. And this actually, instead of having hormones, this prevents fertilization and implantation by making the uterus toxic and causing inflammation. Now, these can last up to 10 years. However, they're not very popular as they can make periods heavier rather than lighter, and they can become irregular, and they're actually quite expensive. Alike to the copper IUD, the Implanon also can change bleeding habits and is just a hormonal rod that is inserted into the triceps. And all these progesterone options are safe in breastfeeding.
The copper IUD is also used as an emergency contraception, right?
Yep, so it is. And it can be used for 5 days post-intercourse. And then we've got just some other options for emergency contraception. So ulipristal acetate and levonorgestrel. So they prevent and or suppress delay ovulation. Ulipristal acetate is a little bit more effective than levonorgestrel. And levonorgestrel can be taken up to 72 hours from unprotected intercourse, and ulipristal acetate is up to 120 hours. And I also just wanted to display here one slide on premenstrual syndrome, which is repetitive cyclical physical and behavioral symptoms occurring in the luteal phase of the menstrual cycle. And then you have premenstrual dysphoric disorder, which is a severe form of this disorder, and it has its own DSM criteria. So just not to know too much here, but just know that you can manage it with lifestyle changes. Hormonal therapy such as the old contraceptive pill can help. There's been some evidence that newer generation OCPs such as Yasmin can help, and in some cases SSRIs if there's severe mood disturbance. So just a few takeaways. So endometriosis often presents with heavy bleeding, and then heavy menstrual bleeding, dyspareunia, pain, infertility. You can get hematochezia if it affects the bowel, hematuria if it affects the bladder. But keep in mind it can be asymptomatic, and infertility may be the only sign in some women. The gold standard for diagnosis of endo is laparoscopic surgery, but you can also manage it medically with pain relief, treating the iron deficiency, treating the heavy bleeding, such as with tranexamic acid or hormonal therapies. And there's also many, many, many different kinds of contraception. Learn what scenarios you use things and how you would effectively counsel someone on contraception or assess their risk factors for appropriate contraception. All right, we're now going to change topics a little bit. So we're going to talk about another common presentation, lower abdominal pain. Very common in both an acute and chronic setting in ONG, but we need to also consider pathology outside of the reproductive system. So we'll start with a case again. So Ash is going to help us through the case. So you're working in a busy metro hospital. Your next patient, Rachel Webster, a 34-year-old woman, is coming with worsening abdominal pain. So Ash, what would you like to know?
Right, so I'd like to get started by getting some general information about the abdominal pain, such as when it started, the characteristic, the intensity, location, whether it's radiated at all, whether there's any aggravating or alleviating factors, and also any associated symptoms.
Yeah, great. So Rachel says the pain started suddenly last night in her right iliac fossa. It's sharp and it also radiates to her right flank, comes and goes. Last night was maybe a 7 to 8 out of 10, but now the pain is coming more frequently. It's probably closer to a 9 out of 10. So she thought she'd come into the ED. Simple pain relief's not helping. She's quite nauseous. She's vomited a few times. She doesn't have any PV bleeding, and there's no changes to her bowel habits or urinary symptoms. So just kind of based off that history, what differentials are you considering?
So it definitely sounds like we're dealing with an acute abdomen in this situation. I'm now thinking of things such as an ectopic pregnancy, given the location of the pain and the patient's age. Also things like appendicitis. This is a really typical presentation with the abdominal pain location. Renal colic, also given the severity and the flank pain. Pelvic inflammatory disease is also something to consider given the acute presentation and the demographic. And also ovarian pathologies such as a ruptured ovarian cyst or ovarian torsion, given the severe unilateral pain and the patient's reproductive age.
Great. Some great differentials, including some things we kind of need to rule out or that are going to require an urgent management. So what would you like to do next?
So I'm thinking that I should ask a little bit more about her past medical history and obstetric and gynecological history, which can help figure out her risk factors for some of these differentials.
Sounds like a good idea. So she's actually normally quite well. She's a non-smoker. She's a non-drinker. She eats a balanced diet. She's never had her appendix out, and she doesn't have any personal or family history of kidney stones, renal tract abnormalities, or kidney issues. She only takes the oral contraceptive pill as a regular medication. In terms of her ONG histories, she's had one pregnancy and one normal vaginal delivery with no complications. Last STI and CST check was normal. She did mention they found something on one of her antenatal scans, but they said to Rachel it was harmless. She had her last menstrual period 1 week ago, and her periods last for 3 to 4 days. They're not bothersome or heavy, and she has a 29-day cycle.
Right. So I'm already thinking that a renal calculi or pelvic inflammatory disease is less likely. This sounds like an ectopic pregnancy would also be less likely, but I think we should still consider it given that it can be life-threatening and it's got the same presentation of an onset of severe localized abdominal pain. I think it's a good idea that to work with the idea that a woman with acute abdominal pain is an ectopic pregnancy until proven otherwise. I'm now also concerned about acute ovarian pathologies such as a ruptured cyst, torsion, and of course appendicitis. It's important for us to still consider things that are not ONG as differentials. What were her examination findings?
Yep, good thing to move on to. So what would you like to know specifically?
Let's start with the vitals. They'll tell us a lot about how sick our patient is.
Great. So blood pressure, 90/65, heart rate, 105, temp, 37.3, rest rate, 16.
Okay, those don't look too good. Those aren't the vitals of a stable patient, especially in a young woman.
Yep, exactly. So we can already see she's hemodynamically unstable, and we haven't even examined her properly yet. And we can also see on general inspection, she's quite pale and uncomfortable.
Okay, that's not good either. What are her abdominal findings?
So she's very tender in the right iliac fossa. She's got some guarding, but no rebound tenderness. On vaginal examination, there's a right adnexal mass can be felt, and there is tenderness in that area.
Okay, so it sounds like Rachel really isn't well. Her vitals aren't great, and there's also some focal tenderness. However, she doesn't seem to be showing any signs of severe peritonism. I'm now thinking more towards an ovarian cyst or torsion due to the findings of a focal abdominal tenderness and adnexal mass. But I think we still need to exclude appendicitis and an ectopic, the latter of which could still be very likely given the right adnexal mass.
Sounds like a good idea. So obviously, like most patients with abdominal pain and ED, you'll do your basic bloods, urinalysis. However, what investigations do you specifically want to order to rule in or rule out your top differentials?
Okay, I'd start by ordering a beta HCG.
Yep, so that's negative.
Can I get an ultrasound?
Sure, and what type would you want?
Can I have an abdominal to rule out appendicitis and transvaginal for the adnexal mass?
Yep.
I'm concerned about the ovarian pathology.
Great. So abdominal ultrasound is fine. The appendix is fine. There's no periappendiceal inflammation or fluid. There's no fat stranding, normal diameter walls. However, a transvaginal ultrasound with Doppler shows mild venous outflow restriction. There's an enlarged right ovary and dilated torsed right fallopian tube with a 10-centimeter diameter dermoid cyst. And there's no signs of necrosis.
Right, so it looks like we're looking at ovarian torsion with a dermoid cyst.
Yep, bingo. That's exactly what's going on here. So ovarian torsion, surgical emergency, and a dermoid cyst is a benign ovarian cyst. We're going to talk about these two pathologies, which are quite closely related to each other and can lead to abdominal pain. So let's talk about ovarian torsion. So this is an R1 condition, and it's basically defined as a complete or partial rotation of the ovary and its ligamentous supports. Classically presents with quite sudden severe unilateral abdominal pain, as it did in Rachel. These patients can be quite unwell, and there's other symptoms such as nausea and vomiting. Some patients will have focal or diffuse abdominal tenderness on exam, and some will have a unilateral adnexal mass that's tender on VE, but not always. They're quite uncomfortable, they're unwell, and peritonism is quite a late sign in this condition and indicates advanced disease. This is when you might have like a rupture of a cyst, there's arterial blood flow restriction, there's infection or necrosis.
Okay. Are there any risk factors?
Yeah, so it can occur spontaneously, but we often see in women of reproductive age during pregnancy, just because there's cysts that grow in response to hormones and the structures are quite lax in the pelvis. Previous pelvic surgery, cases of ovulation stimulation where cysts on the ovary get bigger and can increase the ovary's volume, predispose to torsion. And obviously, as I've alluded to, those with ovarian masses, as in Rachel's case, who has a benign dermoid cyst. And basically, how a cyst or mass predisposes to torsion is it enlarges the ovary, and then the ovary can actually rotate on its pedicle and its ligamentous supports. Now, it's super, super important we untwist the ovary. A torted ovary reduces venous blood flow, and in some cases, arterial blood flow, which leads to edema, ischemia, necrosis, hemorrhage, peritonitis. This is a gynae emergency to preserve fertility. And the diagnosis is mostly clinical, but you can confirm it with imaging, which I've got here with my little buzzword bumblebee. You don't have to be able to interpret this, but whirlpool sign is very buzzwordy for ovarian torsion if you see that in an MCQ stem. So can confirm clinically, but we also have imaging to help us.
Right. So it sounds like our patient's going to need some urgent gynae surgery.
Yep, that's exactly right. So what are you going to do in ED?
Well, first of all, I'm going to refer to gynae urgently. And then I also want to ensure that our patient is stabilized with a doctor's ABCD approach. I want her fasted and nil by mouth, and also have venous access established and start some IV fluids.
Great. So gynae, like any surgery, your main principle is you want to get someone fit for surgery and stabilize them. So think about keeping them fasted, making sure we have intravenous access, we've managed their pain well, and they're a stable patient. Now, in terms of the gynae surgical management, the main principle of management is to preserve ovarian function. So in Rachel's case, because she's quite young and there's no necrosis, we can do a laparoscopic detorsion of the nexa, and concurrent cystectomy will likely be performed given that likely cause her torsion.
What about if she was older?
Yeah, so if she was older or postmenopausal, a self-injectomy or oophorectomy could be considered, particularly if there was necrosis to the ovary or damage.
Okay, and what about the dermoid cyst? How did Rachel get that?
Great question. So now's a good time to talk about benign ovarian tumors and cysts. So these are R2 on your matrix. They're quite two very common things. Very common. They often don't cause issues. They are often found incidentally, as it was in Rachel's case, which is found during pregnancy. They're idiopathic. They can often not cause issues, but they can be associated with some syndromes or some diseases such as endometriosis. And then we also have functional cysts, which fall under this category, which basically assist that respond to the menstrual cycle.
So do we need to know all of these kinds of masses?
Yeah, good question. So you don't need to know all the ins and outs, but here's just a nice little diagram which kind of summarizes it. And there's just a few buzzwordy things you need to know. I'll put them in the presentation notes, but basically we have endometriomas, which are common in endometriosis, and the cyst has like a hemorrhagic sac. We have tuberovarian cysts, or tuberovarian abscesses, which are associated with pelvic inflammatory disease. You've got fibromas, which have a perimenopausal association. You've got teratomas, which is dermoid cysts, which contain all three germ layers. So they can contain hair follicles, teeth, and other material.
Right. So, sorry.
That's okay.
What about functional cysts?
Yeah, so functional cysts respond to the menstrual cycle and are often seen in women of reproductive age, pregnancy, PCOS, and treatments for infertility, as these things are stimulating the ovary. So, for example, a follicular cyst is often the result of non-rupture of a dominant follicle or failure of atresia in a non-dominant follicle. Corpus luteal cysts occur following ovulation, where the corpus luteum doesn't regress, and thicker luteal cysts grow in response to high hormones in pregnancy.
And how do we manage these cysts?
Yeah, so for our functional cysts, often these will just disappear in a matter of weeks. Otherwise, you've got surveillance, and you can prescribe hormonal therapy such as the contraceptive pill that reduce their size. Other benign masses, you've got surveillance via transvaginal ultrasound, and cystectomies if they're large, or oophorectomies in some cases. If you've got a ruptured cyst, it's an emergency, or the cyst has invaded the ovary. This will, depend on patient choice and also the cyst and if it's causing any symptoms.
Okay, so in Rachel's case, a cystectomy might have prevented her ovarian torsion?
Yeah, it may have. We don't know for sure, but again, once these cysts are found incidentally, women are often offered a cystectomy to reduce the risk of ovarian torsion, particularly if the cyst is quite large, over 5 centimeters.
Right, that makes sense.
Great. So now that we've seen Rachel as a young woman, let's consider another scenario. What if I told you she was older, postmenopausal, she comes to you, you're her GP? As opposed to acute abdominal pain, she's had some on and off abdominal pain for a few months. She has increased urinary frequency and occasional incontinence. She finds she's sometimes constipated, but other times she has, loose bowel motions.
Okay, have we ruled out urinary pathologies such as stress or urge incontinence, UTIs, and maybe some bowel pathologies as well?
Yeah, so that's all come back as unremarkable. She's seen lots of doctors. All her gastrointestinal investigations have been normal, including a colonoscopy.
Okay, and what about her examination findings?
So her abdomen is notably distended. She's got vague lower abdominal pain. She says it's become worse. She's lost some weight. What are you worried about?
Well, this could be mass effect from a large cyst or a benign mass.
It definitely could be, with a lot of distension, with change in bowel habit, and given just kind of her age, but also just with the loss of weight, the vague abdominal symptoms, we also need to consider malignancy.
Okay, that makes sense. Has she had any abnormal postmenopausal bleeding?
So she hasn't, but you do some bloods and notice her CA 125 is raised. So what are you thinking of, or what are you going to do?
So I'm suspicious of ovarian cancer now, and I want to make an urgent gynae referral.
Yep, great. Sounds like a good plan. So again, another R1. This is quite a typical picture of ovarian cancer. Buzzword incoming here, or buzz phrase, I should say. So presents quite late with vague abdominal symptoms, and it can often be confused for other diseases that, require scopes or other investigations. So you get on and off abdominal pain for a few months, you get distension, you get increased urinary frequency, and there's also occasional incontinence. You get the symptoms of mass effect that we talked about, such as, which you can see on the screen here. And we don't really know what causes it. We need to know there are risk factors, such as being over 50 years old, having a family history of ovarian or prostate cancer, BRCA1, BRCA2 mutations, early menarche, and nulliparity. So the most common histological subtype is epithelial ovarian carcinoma. You can see there's other types here. Don't worry about learning them. Just know this one's the most common, the epithelial one, and that the serous, high-grade serous is the most common.
Okay, so ovarian cancer can be quite aggressive, can't it?
Yeah, unfortunately is quite aggressive, and it's the 4th leading cause of cancer in women. You get a lot of complications such as metastasis, ascites, pleural effusion, symptoms of mass effect. And treatment basically involves referring to gynae-onc. In early disease, you can do cytoreductive and debulking surgery, and you can use chemo or radiation as a adjuvant. And you're trying to remove as much of the tumor. So often, like, this involves a hysterectomy, bilateral self-injectomy, oophorectomy, resection, depends on the location.
Okay, so you said that chemo and radiotherapy can be used for more advanced disease.
Yeah, that's correct. Radiation obviously can be local, or more systemic, chemo systemic, and then we also have to consider palliation sometimes in these cases. So just some key points. So consider all differential diagnoses, not just ONG. This is good advice just for the rest of your medical career, or if you end up doing ONG, but also for your OSCEs. The examiners are going to want to see that you're screening for other things. Ovarian torsion, it's an emergency. Patients are quite unwell. get them onto gynae surge as soon as possible. Benign ovarian masses and cysts, they're often harmless. Occasionally they cause issues, they rupture, they become painful. Larger cysts may be resected as they can predispose to ovarian torsion. If someone has ongoing abdominal pain, vague abdo symptoms, and they're an older woman, loss of weight, family history, consider ovarian carcinoma. This is managed by gynae-onc with debulking or resection surgery and chemo.
Okay, so now let's start with a brand new case. We've got Louise. She's a 13-year-old girl who's presented to her GP with her mum, who has concerns that Louise hasn't had her first period yet. So Izzy, let's say you're the GP. What would be your next questions?
So I'd like to know about her growth and development, particularly if there's any evidence of any secondary sexual characteristics, such as hair growth and acne. I also want to know about her past medical and family history. Are there any other female relatives that had this similar presentation, such as her mother? Her diet and exercise habits would also be important to understand.
Excellent. So here's what we've gathered from Louise and also some collateral history from her mum. So Louise was born at term with no complications. She had no childhood illnesses, no significant past medical history, and no significant family history. She doesn't have any sisters, but her mum didn't achieve menarche until she was about 15. She hasn't noticed any hair loss, and she says that she's always been on the shorter side in comparison to all of her classmates, and we can see her centile here. She eats a generally balanced diet with meat and veg and plays netball about once or twice a week, as well as her regular PE classes at school. Taking this information into account, what are you thinking now?
I'm thinking maybe this is a case of primary amenorrhea, maybe constitutional growth delay. She doesn't really have any genetic causes for her presentation. Given the family history of her mother's late achievement of menarche, it is possible she'll also achieve menarche at a later time too. However, I still think it's quite important to exclude anatomical anomalies and assess hormonal levels for any other physiological causes.
That's right. I think given her history, it is most likely that Louise will achieve menarche than the average individual, later than the average individual, not necessarily due to any physiological or anatomical issue. But it's important that we confirm this. Before we move on to any investigations and examinations, let's quickly break down the difference between primary and secondary amenorrhea. So to break down the terms, amenorrhea refers to the loss or absence of menses, and primary and secondary refers to the timing of the loss. So primary amenorrhea is when menarche hasn't been achieved at 15 years old, when there's been development of other normal sexual characteristics such as hair growth and acne. Or it's when menarche hasn't been achieved at 13 years old with an absence of the normal development of secondary sexual characteristics. Secondary amenorrhea is defined as the absence of menses for more than 3 months in an individual who previously had regular cycles, or 6 months in the absence of menses for 6 months in an individual with previously irregular cycles. So when we're considering investigations and examinations for this presentation, we would want to take into account various causes of primary amenorrhea. So as we've mentioned, there's constitutional growth delay. There's also hypogonadotrophic hypogonadism, hypergonadotrophic hypogonadism, receptor and enzyme abnormalities, and anatomical anomalies. As you can see, these all cause varying changes to hormonal levels, and so doing hormonal tests can be incredibly important when guiding us towards a diagnosis. However, before we do that, the first thing that we'd want to do is to assess for the presence of the uterus. And we do this through an ultrasound, either abdominal or vaginal, depending on patient age and whether it's appropriate to do a vaginal ultrasound. Once we've assessed for the presence of the uterus, let's say in this case, Louise does have a uterus, we'd want to assess her FSH and LH levels. And we'd also want to exclude other anatomical anomalies, such as an imperfect hymen, vaginal atresia, and the presence of a transverse vaginal septum. If FSH levels are elevated, we would be considering things such as primary ovarian insufficiency, such as Turner syndrome, Swires syndrome, and premature ovarian failure. A normal FSH would be indicative of constitutional growth delay or possibly hypogonadotrophic hypogonadism. So let's say in this case, Louise had her ultrasound done, we could see that there was a uterus, and also her FSH levels have come back negative. Oh, normal. So if all tests come back negative, there wouldn't be any need for any intervention or management at this time, and would encourage Louise to return if she has any other concerns. So in this case, the diagnosis is most likely going to be constitutional growth delay. So if we change the case a little bit with different patient demographics, Louise is now a 16-year-old girl, G0P0, with no significant past medical history, who presents to the GP with concerns regarding an irregular period. Given this, what are you concerned about, Izzy, and what questions would you like to ask?
Given that this patient is concerned about her period, I do want to know a bit more about her period and what she actually means by irregular period. I would ask her questions about when she first started her periods, any changes to her period since they begun, the amount, length, and her cycle.
Great. So as you've mentioned, it's really important that we have as full an understanding as possible about Louise's period and any changes that might have occurred over time. And also, as you mentioned, it's really important that we actually clarify what an irregular period means to her. So after speaking to Louise, you find the following. Louise got her period for the first time at 12, but she noticed that she was having some hair growth on her in her armpit and on her face well before her friends at around the age of 10. Until 4 months ago, she always got a period every 3 to 4 weeks. She used 4 to 6 pads a day and didn't really have any other symptoms. Her last period was 5 months ago. She's currently not sexually active and has never been, and neither her or her mum are aware of any significant family history. Izzy, what's your next step?
Well, at this point, I'd be considering a few differentials, including polycystic ovarian syndrome, PCOS. Because she's presenting with symptoms of secondary amenorrhea, PCOS would be the most common cause in a patient of her age. I would also want to ask her some more questions on history and also perform some blood test imaging to confirm the diagnosis.
Spot on. So the first thing to recognize here is that we've got a presentation of secondary amenorrhea. In Louise's case, she did previously have regular periods and she's now developed an irregular period with the loss of menses for the last 4 months. There are several causes of secondary amenorrhea, as you can see here, but as you've mentioned, PCOS is the most common cause in Louise's age group. PCOS is a condition that we don't actually fully understand, but there are some theories regarding its pathophysiology. However, before we can understand what goes wrong in PCOS, let's have a really quick look at what is actually supposed to happen. So we're going to have a very quick overview of the ovarian and uterine cycles. So essentially, there's 2 cycles that are happening at the same time, and I find that it's usually easier to look at one and then try and link in the other. So if we look at the ovarian cycle, the first step is the development of the primordial follicle, which is stimulated by the FSH released by the anterior pituitary. The primordial follicle then develops into the primary follicles, and FSH stimulates about 6 to 12 primary follicles to become secondary follicles. The granulosa cells then divide into theca interna cells, which secrete estrogen from the antrum, and theca externa cells that form the capsule. The estrogen from the theca interna cells then allow for the formation of the antrum, and at the same time, the zona pellucida also forms around the ovum. As per the axis that's on the other slide, estrogen usually causes a reduction in the release of FSH from the anterior pituitary through negative feedback. But FSH is key for continued follicular growth. So estrogen actually causes an increase in FSH receptors on the follicle, which creates an FSH surge. The graphene follicle is formed as the FSH surge causes an increase in estrogen. And at the same time, FSH and estrogen allows for the endometrial proliferation, which coincides with the proliferation phase of the uterine cycle. The increase in estrogen also allows for an increase in pulsatility of the GnRH. Ovulation then occurs due to a LH surge. The increase in LH changes the estrogen-producing thicker cells to progesterone-producing lutein cells. The zona pellucida and the corona radiata continue to surround the ovum as it exits the ovary. The secretory phase coincides with the presence of the corpus luteum as it remains in the ovary, as the corpus luteum continues to release both estrogen and progesterone. The progesterone from the thecal cells allows for the continual thickening of the endometrial functionalis, and progesterone from the lutein cells, through negative feedback to the hypothalamus and anterior pituitary, prevents the release of an ovum from the other ovary, allows for the maintenance of the endometrium, and also helps to increase the basal metabolic rate to increase temperature, which generally promotes fertilization. Without fertilization, the corpus luteum lasts about 14 days and then becomes a corpus albicans. Menstruation occurs when the corpus luteum begins to degrade and there's a loss of progesterone, which causes arterial constriction in the endometrium, similar to what we would expect to see in a myocardial infarction. And this then allows for menses. So PCOS is a condition that patients generally start to present with in their adolescence, and it can present with a variety of symptoms that you can see here. So there's menstrual irregularity, insulin resistance and metabolic syndrome, skin conditions, and psych conditions. In this case, Louise has presented with menstrual disturbances. This can include irregular, infrequent, and heavy periods, and this is due to the fact that immature eggs are unable to ovulate. The pathophysiology for PCOS is not completely understood. However, we think that it's closely associated with obesity. It's thought that the increase in peripheral estrogen synthesis from adipose tissue decreases peripheral sensitivity to insulin. The reduced insulin sensitivity leads to hyperinsulinemia. And this is thought to account for various symptoms that patients can present with. Patients, as I've mentioned, can also present with symptoms of hyperandrogenism, which can present as excessive facial and or body hair on the sideburns, chin or upper lip, hirsutism, acne, oily skin and excessive sweating, acanthosis nigricans, and alopecia. It's also thought that insulin resistance can result in truncal obesity and weight gain. We've also found that mental health can be severely affected in patients with PCOS, as we can see mood changes and patients can experience depression, anxiety, and low self-esteem. PCOS can also cause infertility, and this is thought to occur as hyperinsulinemia increases androgen production in the ovarian theca cells. This increases LH secretion, which interrupts the balance between LH and FSH. This then impairs follicular maturation, leading to cyst formation, which can present as anovulation or oligoovulation, which is a cause for infertility. PCOS is also associated with an increased risk of endometrial cancer due to endometrial hyperplasia, as there is often unopposed estrogen during anovulatory cycles. So that's a lot of information, but given all of this, Izzy, what are you thinking in terms of investigations and examinations?
Well, on examination, I just want to do a general inspection. I'm looking at body habitus, given that there's an association between obesity and PCOS. I'd be also looking for signs of hyperandrogenism, such as acne, hirsutism, oily skin, alopecia, and excessive sweating. Now, in terms of investigations, important to exclude pregnancy. I'd also want to be assessing other differentials, such as hyper or hypothyroidism with thyroid function tests, and also imaging of the ovaries and ultrasound, just to look at some things for PCOS, but also other structural causes.
Great. So you got almost everything on examination. As always, general inspection can be a key clue in your diagnostic approach, and in particular, signs of hyperandrogenism is quite unique to PCOS. Other things that you could take note of when you're considering PCOS is checking blood pressure. This is primarily because of its associations with metabolic syndrome, but it's also important to assess before managing PCOS. As we'll come to discuss later, PCOS can be managed through the use of the oral contraceptive pill. And as Izzy mentioned earlier in our PSP, it's important that hypertension is assessed. It could also be pertinent to assess for an enlarged polycystic ovary on bimanual exam. But given that this is quite a sensitive and invasive examination, it might not be appropriate for the patient. Investigations for PCOS can be quite broad, as it covers quite a few bases, as we are looking to exclude other differentials. So as Izzy mentioned, things such as hyper or hypothyroidism, but it's also important to assess the effect of PCOS on the presence of possible metabolic syndromes. And as Izzy mentioned, in almost all cases of amenorrhea, it's important to exclude pregnancy. So I've personally found that it can be quite helpful to split investigations into bedsides, bloods and cultures, and imaging. So on bedsides, a beta-HCG and BSL. Bloods and cultures, we can do TFTs, prolactin, look at lipid levels, and also possibly do an OGTT. And on imaging, we can do either a transvaginal or an abdominal ultrasound based on the individual patient. There's also a PCOS screen. So it essentially looks at the hormonal levels at various stages in the cycle. So at day 3, we look at FSH and LH and estradiol. So in a patient with PCOS, we would expect to see low FSH and high LH with normal estradiol levels. We also do a screen at day 21, which is mid-luteal phase. And we look at a variety of things. So we look at progesterone, LH, we look at the androgen profile and sex hormone binding globulin. We look at blood lipids and anti-Müllerian hormone. And you can see what we would expect to see in a patient with PCOS here. There is also something called the Rotterdam criteria. This can also be used as a diagnostic tool. And essentially, we would want to see 2 out of 3 of these criteria achieved in order to give someone a diagnosis of PCOS. Notably, a patient doesn't need to have polycystic ovarian morphology in order to have a PCOS diagnosis. So as I mentioned before, PCOS can present with a wide variety of concerns and symptoms. And so PCOS management is multifactorial, and it focuses on managing the symptoms that a patient presents with. So for menstrual disturbances, we can use COCP. For weight control and metabolic syndrome, lifestyle changes can be very helpful. As we've seen that a reduction of around 5%, a weight reduction of about 5% can greatly reduce insulin resistance. Metformin also plays an interesting role in PCOS management. And also for mental health, we'd want to refer to mental health professionals. So in Louise's case, there aren't many other symptoms, so it would be okay to just prescribe her the COCP with the appropriate counseling, as Izzy discussed earlier. We'd also want to encourage Louise generally, but also due to PCOS's close association with obesity, to have a balanced and nutritious diet and continue to engage in physical activity to aim to maintain a healthy weight. And there's just some information here about metformin and its role in PCOS. Okay, so let's change the case one more time. Louise is now a 49-year-old female G3P3 who's presented to her GP with changes to her menstrual cycle. Now, Izzy, this is obviously a very different patient demographic. How is this going to affect your history, investigations, and differential diagnosis?
So I think the increased age would immediately put cancer further forward on my differential list, so I'd be sure to exclude that early, as well as taking into account the possibility of the onset of menopause and other endocrine disorders. Before I proceed, I'd like to ask her some questions about her period, when they started, her normal cycle and flow, and when this change began, as well as asking her about any other symptoms she might be experiencing. Unexplained weight loss, fever, night sweats, fatigue, the classic B constitutional symptoms, hot flashes, changes to her mood.
Great. So I think that taking note of her age and adjusting your differentials is key to ensuring you prioritize your investigations and work up to be most appropriate for your patient. So Louise had achieved menarche at 14 and her periods were always regular, 4 weeks apart, and she used about 4 to 5 pads a day. She has noticed that her periods have become more irregular in the last year. However, before they became irregular, she actually found that they became more frequent and heavier for a couple of months, where she was requiring up to 7 to 8 pads a day. At this point, she hasn't had a regular period in 7 months. She's also noticed that she gets warm very quickly and she's been snapping at her husband more than usual. She also often finds herself feeling quite anxious. She hasn't noticed any weight loss, night sweats, or fevers. Izzy, what do you want to do next?
Well, given her history and age, I think Louise is most likely going through perimenopause. My next step would be assess her symptoms and how she's feeling to see if she would benefit from hormonal replacement therapy.
Yeah, that sounds like a great plan. There are some investigations that are available if you'd like to confirm for the presence of menopause. However, they aren't very sensitive and they're not very high yield. So Izzy, you mentioned perimenopause. Can you explain the difference between perimenopause and menopause? And how does this play a role into any hormonal replacement therapy that we can offer to our patient?
Yep, so perimenopause is the period of menstrual irregularity shorter than 12 months after the last regular period in an individual with an ovaries and a uterus, while menopause is a distinct point in time that is 12 months after the last menstrual bleeding in an individual with ovaries and a pelvis. Now, in terms of how it impacts the treatment options, for individuals who are in perimenopausal period, they will be offered the cyclical dosing regime, and while menopausal women will be offered a continuous dose of hormonal replacement therapy.
That's exactly right. So as Louise has only noticed menstrual irregularity for 7 months, she would be considered to be perimenopausal. And so if she is experiencing symptoms that will be on a slide that will be in the slide set, she can have HRT offered to her in a cyclical dosing regime. And the aim of this essentially is to mimic the expected rises and falls of estrogen and progesterone that we would expect to see in the normal cycle. And this allows for bleeds that are protective against endometrial hyperplasia and dysplasia. Once she achieves menopause, which is likely to be in about 5 months, if she's continuing to experience symptoms, she can be switched onto a continuous dose. It's important when administering HRT to factor in whether the patient has had a hysterectomy or an oophorectomy and adjust the medications accordingly. For example, a patient who's had a hysterectomy doesn't need progesterone, as the main role of progesterone is to be protective against endometrial hyperplasia and dysplasia. Additionally, once a patient has achieved menopause, their bone density begins to drop dramatically, so it's important to consider other management options to prevent osteoporosis. So essentially what I've done here is I've got some screenshots from ETG, as they've got a very comprehensive explanation of when HRT or MHT would be appropriate and which ones would be appropriate for what type of patient. And so I thought that instead of talking through all of these, it would just be easier if you guys can just have a look on the slides. So let's say that you have adequately managed Louise's perimenopausal or menopausal symptoms, but she returns to you with concerns of a lump on her vulva with some pain on urination. On further history, you find that she has a history of HPV, but has otherwise been well. She has no smoking or alcohol history. What do you want to do next?
Well, given her presentation of pain on urination, I would be concerned about a UTI. So I'd just be asking about frequency, quality of pain, and any changes to odor and appearance of her urine, and if she's been experiencing fevers or chills. I'd also want to examine the lump as well as ask her more questions about the lump, such as is it painful to touch, has she noticed any bleeding, and when she first noticed it.
Great. So in further questioning, Louise tells you that she hasn't noticed any changes to her urine aside from some occasional pain. In terms of the lump, she noticed it a few weeks ago. She hasn't noticed any bleeding, but she does think that it looks a bit discolored in comparison to the other tissue in the area. She also noticed it's a bit itchy. On examination, you find a lump consistent with Louise's description. There appears to be some red, purplish discoloration, and it appears to have a plaque-like growth. There doesn't appear to be any other changes to the area. No other lumps, no nodes were palpable, and there was no discharge or blood. What do you want to do next?
Well, my primary concern here would would be if this is vulval cancer. I'd want a biopsy and send it to histology. If it is found to be vulval cancer, it would then be a case of surgical resection, whether it be a partial total vulvectomy and possible radiotherapy if necessary.
Yeah, so given this presentation, this is the most likely cause. And if the biopsy comes back positive for vulvar cancer, we would then, as you mentioned, offer her surgical resection. So either partial or total, depending on the size of the lump or the cancer, and also the severity. And if necessary, we would want to consider radiochemotherapy and continue to monitor Louise. So that's basically the most of our PSP. There's also a couple of slides here on two of the arteries, vulvodynia and vaginismus. But thank you all for coming. We hope that was helpful. If you've got any questions, please feel free to contact us, and we'd be more than happy to help. Thanks.
Thanks, everyone.